Okay, welcome everybody. Welcome to our first conversation in 2021. Thrilled to be together. And I am Rebecca Berman. I am our moderator this evening and thrilled to be here with all of you live and everybody watching on YouTube and beyond. We are with our esteemed host, Glenn Grossman, who is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs within the United States and abroad. All views expressed today are his own. So thank you to everybody. You sent in lots of great questions this week. And certainly, as always, if questions should arise during our conversation, please send them to me privately via the chat button in the bottom, and I will do my best to weave your questions into the conversation tonight. If Glenn is unable to answer your questions, if we're unable to get to your questions tonight, I will hold on to them. Glenn will work on your questions during the week, and we will answer those questions during our conversation next week. You'll see that a lot of the questions that came in tonight are questions pertaining to the different vaccines. So hold on tight. We're first going to go on a rapid trip around the world, and then we are going to dig into lots of details about the vaccines and lots of good details that you and your family will really want to know. So Glenn, what is going on, both here and abroad? What has happened? Please tell us more.
Thanks, Rebecca. All right, good to see everyone again this week. Thanks, Rebecca, for the introduction. I feel like I should be giving an introduction to you every week also because of the great moderating work that you're doing. All right, let me see. Here is where we are. All right, so as I've mentioned in previous weeks, the data is a little bit messy over the last week or two because of Christmas and because of New Year's. And so the data is a little bit weird. It doesn't mean that the cases have stopped or gone down. Rather, all it means is that it's a data issue, data capture issue. And we see the data capture issue in terms of the number of tests, that the holidays probably did impact the testing. And so in terms of how often people were getting tested, whether the clinics were open or not, if they were not 24 hours, et cetera. Daily cases, so I don't trust this as much. Hospitalization. So this comes directly from the hospitals and it's updated automatically. So this, I do trust this data a lot. And we see that this is continuing to rise. This is currently hospitalized, not new daily hospitalizations. But yet what this continues to go up. It has not peaked. It's going to probably continue to go up for a couple more weeks, maybe not quite a couple more weeks, but we should see, based on some of the forecasts, that if we expect that the peak deaths are going to occur in approximately 2 to 3 weeks, then that means that the hospitalization should start to peak within the next week or so. But it all depends on the stay-at-home orders that we have around the country and things like that. And so that's still it's going to be unclear to see what happens in the next few weeks. But we'll know in a couple weeks whether these forecasts are on target for hitting the peak of the current surge within a couple weeks based on the hospitalization rate that we'll see in the next week or two. All right, in terms of the hospitalizations, again, it's a data issue there, but if we look with a little bit more clarity, let me put this down here. All right, so now the key thing that we need to look at here is the average deaths per day on a weekly basis. So this what's called a spline, the spline curve. And so and again, I don't trust this data because it just wasn't reported for so many days over the Christmas holiday and this past week. I don't know how reliable it is, but what I expect based on what we saw for the similar dip in Thanksgiving is that it's going to come out and the pace that it was increasing before the dip is going to be roughly the same pace after the dip. And so that means that I expect within another few days or so, so on Tuesday and Wednesday, the data that comes in is going to be pretty high. I think we're going to exceed 4,000 on Tuesday or Wednesday, but it's not going to be actual deaths that day. It's just going to be the gap that's going to continue to be filled in. So I think that the rate that we're seeing is going to continue sort of around at that line, essentially, the average that we see once all the data comes in. In terms of the hospitalization rates currently, this is again another great way to see what's going on around the country. So this is the distribution of where the hotspots are in the country. So you can see where all the action is. Like California over here has a lot of cases right now. So when you're wondering where are all the cases in the hospitalizations right now, a large amount of it is in California. But California is a very large state. Texas, you see that's coming in second, also an extremely large state. Florida, very large state. So another way that I prefer to look at this is to look at it per million. So you sort of normalize based on the number of people in the state. And when you do that, you see that although California is doing poorly, there are a lot of other states that are doing a similar quantity or not too different in terms of so when you look at the Souths are in the same ballpark as California is coming in as. When you see Arizona and you see Nevada, these are also very they're exceeding the rate at which California is doing. So in terms of the experience within these states, the states with these large black circles are not doing well right now. Their hospitals are really not doing well. I mean, they're handling it well. They're handling it with great skill, but they're being overwhelmed by demand because of all these people that have COVID-19. And so it's really tough right now. States in blue with the blue circles are better now in terms of the amount of COVID-19 cases that they're hitting. If you recall, North Dakota put some constraints, more restrictions in place than South Dakota did. And so as a result, South Dakota, even though it's already past its peak, it's not going down as fast as North Dakota is dropping. And so that's all a management decision. So people are continuing to die at a high rate. Right now, we're looking at hospitalizations, but people are continuing to die at a high rate in South Dakota simply because of the governor and the General Assembly, their decision on how to run their state. Anyway, so this is where we are in the US. On the global level, so you can see, let me put, so this is the 7-day rolling average. You can see that the United States is really not doing well relative to much of the rest of the world. There are some places in Europe that are not doing well. Generally, the bigger countries are doing better. The smaller countries are not doing as well. So you see that on average, we have 690 cases per day. Per day. I'm not quite sure. Oh, this is 690 per million people per the last 7 days rolling average. All right, and so what we look at here is France is doing a lot better. Germany is doing a lot better. A lot of Europe shut down. UK is not doing great at all right now, but they have more restrictions in place than the United States does. So they should start to be doing better soon. All right, in terms of, so this is when we're looking at cases. In terms of mortality, you see that we're also, in terms of the large countries that we're talking about, the big economies, we're really not doing very well relative to much of the rest of the world. This is in terms of deaths. South Africa got hit pretty hard over their winter, and then they've had some lingering issues. But Europe is being hit. It's varying a lot around Europe, but that's the same. It's varying a lot around the United States too. That was my point here, is that states have dramatically different variation in terms of how successful they're doing. And then, yeah, those are the two main things that we can look at. Otherwise, I want to get into, before we get into other interesting things, I have a surprise. So we've done all of these weeks of learning all this stuff about COVID-19, and I thought, we've made it through 2020. We've completed this. For many of you, your first intro epidemiology class in 2020, but it's not complete unless we have an end of year exam. So everyone, here is your end of year exam. These are all true false questions. You will not be graded by me. I will not see your answer. But let's
Pop
just
exam. Oh
it's
no.
a pop final exam. Isn't that the worst? But let me go through the questions because I think that there's some interesting things. These are common misconceptions that hopefully everyone who's watched some of my videos already knows the answer to. But if other people are new to it or they still have questions, then these are some interesting just highlights that we've discussed over the course of the last year. And if you have any questions about any of the answers, then we can just spend a few minutes today as well going through some of them to say, okay, what evidence is there to support this or whatnot. All right, so here are the questions. There's only 12 questions. I was trying to limit it to 10, but I didn't have time to constrain it to the best 10. So here they are. True or false? 1, natural herd immunity is another name for the idea that public health workers should not try to stop outbreaks of epidemics. 2, although there are many types of scientists that studied and worked on the COVID-19 epidemic, the area of medical science which focuses on the distribution, determinants, and management of the COVID-19 epidemic is called epidemiology, and those scientists are called epidemiologists. 3, a SARS-CoV-2 variant was found naturally in bats years before the epidemic started in 2019. 4, SARS-CoV-2 infections and deaths are being undercounted rather than overcounted. 5, the publicly available COVID-19 vaccine is safe and effective. All eligible people should prioritize getting the COVID-19 vaccine as soon as they are able. 6, SARS-CoV-2 is 2 to 3 times more contagious than the average seasonal flu. 7, around 10% of people who got COVID-19 did not fully recover after multiple months. 8, a cure is available, but it only works if taken before severe symptoms start. 9, hydroxychloroquine is not an effective drug for treating hospitalized COVID-19 patients. 10, some countries have been able to get the COVID-19 epidemic under control or eliminated simply with the widespread use of masks, social distancing, test and trace, and other public health measures, and the limited use of stay-at-home orders. 11, some people have been reinfected with SARS-CoV-2, and the symptoms from the second infection were more severe than the first. And the last one, 12, in the United States, over 1 in every 1,000 people who were living in the United States in January of 2019, over 1 in every 1,000 people died from COVID-19 in 2020. All right, so think about the answers. So now I'll give you the answer. Every single one of these was true. So any that you might have thought were false is not right. And what I would say is if you got more than 5 false, then you probably failed the test and you need to redo it. Retake the course this coming year. Unfortunately, I hope that much of the United States passes this test, because if areas of the United States fail this test, they're probably going to have to redo it this year in terms of the epidemic and the outbreak. So does anyone have any questions about any of these? Because they're all, when you think about them, some of them seem obvious, but some of them maybe don't seem so obvious.
Well, first of all, this was a lot of fun. Thank you. At first I was nervous. This pop exam made me a little nervous. I don't know about everybody else, but I was a little bit nervous, and it was challenging, but this was excellent. So we thank you for this pop exam. But I have to say, before COVID-19, whenever somebody would say, what does an epidemiologist do? My response was, well, you know that movie Outbreak? Remember that? So that's what the epidemiologists focus on. So I think it's pretty safe to say that most people now know what an epidemiologist does and is.
I agree. The funniest thing is, so a year ago, before COVID-19, for most people, which is really funny, but if I was at a bar or at a party, if I told the typical regular person that I was an epidemiologist, the standard response among the majority of people was, "Oh, does that mean you study skin?" Because they thought, "Oh, epidermis, that must be epidemiology." They didn't realize that a dermatologist studies skin and an epidemiologist, it's related to the word epidemic. And so that's what epidemiologists do. But yeah, cool. All right, so let's go on. Rebecca, if you can go on to your next question or next area, then we can start with that.
Well, thanks again for that pop exam. Excellent. And thank you for being a wonderful professor, because I think we all scored very, very well. I know we all scored very, very well on that very difficult exam. Your pupils all did amazing. So congratulations to all of us. Okay, so lots of questions about the vaccines and the rollout. Can you give us a quick update on the rollout of the vaccine, where we are, how many people have taken the vaccine, and where it's available?
Yeah, sure. So first, let me go through what's been approved in different parts of the world. I'm just going to go through, this is the New York Times vaccine tracker that I find very helpful, but I'm just going to flip through real quickly to the vaccines that have been approved. So this one that we're looking at is the Pfizer vaccine. It's been approved in some countries and has been given emergency use authorization in some others. So for instance, the vaccines in the US are actually being distributed under the emergency use authorization, not under a typical vaccine approval. So it's still, and that one of the benefits of that is that there's extra monitoring and other things that are going on during this rollout. And so we're still monitoring the vaccine for safety, efficacy, and with definitely a lot of transparency and visibility. Europe has also approved the Pfizer vaccine with the emergency use authorization, their equivalent, Switzerland as well. Some other countries in the Middle East have. In South America, there's some use of the Pfizer vaccine as well. Moderna has more limited use, and it's basically looks like it's primarily in the North America that it's being used. And that was part of the reason that, so the Moderna vaccine, the United States paid did two things. One, they paid money just simply to help stimulate Moderna, their trials and stuff, so that they could pay. So they had a large bucket of cash to run the trials. In addition to that, they also, so this was Operation Warp Speed that did this. In addition, they also, the United States agreed to buy a certain amount of doses of the vaccine way before the clinical trials were done, which is not typical at all. And so as a result, it enabled Moderna to go a lot faster than it normally would have. For Pfizer, even though that wasn't part of Operation Warp Speed in the sense that we gave them extra money to pay for the trial and the manufacturing and whatnot, we also reserved drug doses from them. And so that also, because they knew that they could expect to receive it, that also allowed them to borrow against it and to go a little bit faster. However, Europe they had their equivalent of Operation Warp Speed in Europe. Other countries also did Operation. They didn't call it Operation Warp Speed like we did in the US, but they had similar programs, and they also paid Pfizer large buckets of money in order to make them go faster. So Pfizer and Moderna both were well funded, but you can see because lots of other countries contributed to the Pfizer operation, they had early access to the Pfizer vaccines as well. All right, so in addition to Moderna and Pfizer, those are the two mRNA virus, those mRNA vaccines are the ones that are approved in the US. In other parts of the world, there's a couple of others that have been approved. So for instance, this is the Russian vaccine that they've done. Clinical trials have not been completed there, but Russia and also Argentina are starting to use that one. I believe that this one was based on the adenovirus. I don't remember the specifics about this vaccine right now, though. But this is the one that was in Russia. In addition, there's the AstraZeneca vaccine has had limited release under emergency use authorization in India, Britain, Argentina, a couple of others. China has released a couple. And so, for instance, let me see if I can get it real fast. So China has this one from Sinopharm that's been released in China and a couple countries in the Middle East. And then there's also Sinopharm has released, I guess, another version of the vaccine as well. So anyway, those are the major ones. So it looks like there's this other one, Bharat, in India that has emergency use authorization. So those are the major ones. When we look at the, when we look here, that's not what I want to show. So this is the current number of doses administered. This is the total dose. That's not what I was looking for. Here's what I was looking for. All right, so what we're looking at here is the vaccination doses administered per 100 people. So this, another way of saying this is the percent, because per 100 people is the percent of the population. And I think the English, most people understand percent better than per 100 people. So I'm not sure why they put per 100 people, but all right, it is what it is. And so you can see the different distributions around the country. Hopefully in the next few weeks and months, we're going to see a lot more countries starting to get vaccinated, and the colors go from light blue to dark green very quickly. In fact, it looks like there's going to have to be a different color scheme because this only goes up to 16%. So hopefully sometime and then in the next few months, we'll start to hit high numbers. Interestingly, when you look at the countries across the world, there's wide variation. Already, Israel's clearly far ahead in this race to vaccinate the population. Israel has vaccinated essentially 13% of their population already, which is, they're going at a very fast rate. They're vaccinating approximately 1% of the population per day. So within around 3 months, so we're talking about before spring. I mean, we're early spring. We are, or late spring, mid spring, let's say. We are already going to have we're going to reach herd immunity for sure, and if not, the vast majority of the population that's going to be vaccinated. I haven't been looking for any of these countries on rather on vaccine hesitancy. So I don't know what mandates are in place or whether it's voluntary or whatnot for now. But I know at the beginning, vaccine hesitancy doesn't really matter anywhere because people who are hungry for the vaccine are going to be eating up the vaccine. Well, actually not eating, that's the wrong word, but they're going to be getting the vaccine as soon as possible. Next after Israel is Bahrain, also has a great public health infrastructure that's rolling this out. United Kingdom and United States are pushing. And so you can see the rates. Europe is slowly getting on board. But you'll recall that the vaccines were only approved within the last couple of weeks or so. So it takes some time to ramp this stuff up. All right, in terms of doses administered so far, this is absolute. So as of yesterday, Saturday, January 2nd, the United States has administered over 4 million doses. So over 4 million people have already received their first dose. There are data limitations. I know that the vaccines seem like they're not being reported as quickly as some of the other data that's coming in. So I don't know if this might be undercounting to a significant degree. I don't know exactly, but we're already starting. The interesting thing here is this daily vaccination rates. So when you look at the United States, you can see that we've been increasing the daily number of vaccine doses administered a lot. It looks like we're increasing the doses at a rate of approximately 25,000 per day. So even though we're starting low, we're increasing it. I wish we were increasing it faster, and we can talk about that in a little while in terms of some of the issues that have come up in the last week. But we are increasing it 20. So it's roughly, looks like the rate is roughly 25,000 per day that's increasing. So yeah. In terms of the United States, so some states are getting the vaccine distributed much more rapidly within their state than others. And so this is not a function of the doses that they've received. It's a function of the state governments and the public health leadership delivering this out and making sure people get vaccinated. And so you can see that it's been slower uptake in some places, faster in others. Darker means faster, a larger percentage have been vaccinated. Um, Interestingly, so there is variation. Again, this is not like the vaccine hesitancy map that we've looked at previously, because everyone, the people who want the vaccine the most are the ones who are getting it right now. So really what this is measuring is simply the ability of the infrastructure in place, and the public health infrastructure and the partnerships with the hospitals and the healthcare professionals who are administering the vaccine, just how efficient they are in terms of administering. Interestingly, there's this question of how many doses were distributed versus how many shots given. And you see that there's wide variation in terms of how quickly the states are giving the shots that they've received. So some states, New York is broken out. This is the New York Times tracker that I'm looking at. So he put extra information about New York. But you can see that some states, like Georgia is an example, only 17% have been sent out. Whereas in other states, let's look at Ohio as an example, over half of the vaccines have been administered. So that's something that we need to be paying attention to. We know that even though the CDC has recommended different populations get priority treatment in terms of where they get, how quickly they can get the vaccine, typically right now we're focusing on healthcare providers first. And then after that, we're going to focus on high risk populations and go from there. Right now, it's long-term care facilities that are being prioritized. But in some states like Florida, it's really unethical. But Florida is not the only state, but it was one of the first where they just didn't even bother prioritizing. They just opened it up and said it was. If you remember, there was a hurricane in Puerto Rico early in Trump's presidency, and he went in and just started throwing paper towels around to the crowd, and it was totally disorganized. It wasn't systematic. It was just for show. And in Florida, they've just had this haphazard, random, chaotic approach to just allowing first come, first serve without regard for the two things that we've been prioritizing. The two reasons that the way that we think about who should get vaccinated first are based on two things. The first is the severity of the disease, how whether people are high risk of getting severe disease if they get infected. And then the second is if they are, or I guess there's three things. The second is if they are at high risk of spreading the disease. And then the third, the reason that we're doing the healthcare providers urgently is because we need them to treat people. And if they get sick and they're knocked out of commission for a couple of weeks because they have COVID-19, then that limits the healthcare capacity to address COVID-19 within the hospitals and within the public health realm. So those three things are the major ones. And Florida, they just opened it up to anyone who is over a certain age, and it was just terrible. And the worry now is that with the vaccines setting to expire, so I think both of these vaccines have around a 30-day expiration window, and a lot of these vaccines were received 2 weeks ago, which means another couple of weeks, and some of this volume of vaccine is going to start to expire. And so then this is very disconcerting because this vaccine is precious. We don't want to get rid of any of this vaccine simply because of poor management. And so that is an issue that we'll also talk about in a little while. Rebecca, I'm going to leave that here and then go back to you for questions. We can revisit this.
Thank you, Glenn. Thanks for taking us through those details. So I'm going to ask Debbie to unmute, please. Debbie had a question about the vaccines, and Debbie, take it away.
Hi, guys. Glenn, thank you again for being such a guru and a major source of comfort every Sunday. Thank you. Thank you. My question for you is, if somebody receives the vaccine, how quickly is it safe for them to feel comfortable that they cannot get COVID without the booster? Like, are they safe once they get the vaccine? How does it work?
So it ramps up, and so they tested people in the vaccine trials, and after approximately 14 days, they reached the maximum benefit of each of the doses. So the first dose, after 14 days, it was around 50% protective. And so it takes a while to generate this immune response. So it's going to vary. For some people, it might be 10 days, some people 14 days, but that maximum threshold was reached by around 14 days. Certainly the first few days, no one's going to have any sort of immune response that's going to be sufficient to really generate any sort of protection. So 50% protection means if 10 people are exposed and they would have been infected, then only 5 of those who are vaccinated are likely to have severe disease or get disease. And then with the second vaccine dose, so that's roughly a little less than a month later when they get the second dose, then it goes up to much higher protection. The most serious severe disease that we're looking at, we found that it's roughly 95% protective. And again, that's 14 days after the second dose is when it has ramped up, so it's 95% protective. So I'd really play it safe. I would continue limiting, assuming even for most people who get these vaccines, I mean, the healthcare professionals, there's not much they can do right now. But people who, as more and more people are able to get the vaccine in the coming weeks, I would assume that you have not been vaccinated. Don't change your behavior. Continue wearing masks. Continue isolating yourself as much as you can. Continue the same type of behaviors that we've been doing over the last few months, and until the second dose. After the second dose, then you can relax a little bit. There's still questions about whether people can still transmit the virus after their second dose and whatnot. We can talk about later as more information comes in. But in terms of people getting infected and getting severe disease, this is going to keep the vast majority out of the hospital after that 14 days after that second dose. So that window of time, roughly a month and a half, don't assume that you have protection from the vaccine. Great. All right, Rebecca.
Okay.
Thank you, Glenn.
Thank you.
Thank you, Debbie. Okay, so Glenn, you've said multiple times now that you very much support for all of your friends and all of your family to go out and get these vaccines if and when they are able to get the vaccines. And so do you still believe that your friends and your family and everybody who's watching and listening should take these vaccines? Tell me more, because there are people who are still hesitant. Absolutely. And so now that we're months into this, and well, not really months necessarily, since these vaccines have received these emergency use authorizations, do you still firmly believe this?
So let me talk about that. So first, let me talk about the big question I've heard over the last week or two is this question about how safe it is based on this new technology. Because people hear the word mRNA, there's never been an mRNA vaccine before. How safe? How can we possibly know how safe it is? So I thought I'd spend a few minutes describing mRNA in general. How long have we known about it? How has it been used in medicines before and therapeutically? And so just so you can get a little bit more comfortable with it. But to answer your question, should people get the vaccine? Everyone should get the vaccine. Every eligible person should get the vaccine as soon as they are able to. There's no reason in terms of safety or efficacy not to get one of these mRNA vaccines. But so just briefly, I'll go into the RNA. So messenger RNA was discovered in 1961. So we've known about it for decades. The amount that we've known about it had increased exponentially between the 60s and up through the 90s, 2000. We know so much about it. Not me personally, but the field of genetics is really powerful. The field is enormous. They've been doing it for so many decades. this is like many generations of professors working on it. A professor in the 1960s would have had graduate students, and they would have gone on to become professors and then have their own graduate students. And so you're really talking about generations and generations of academics, pharmaceutical companies, and whatnot working on this. So we have a huge amount of experience with genetics. Genetics is frequently people are talking about DNA. This is not DNA. And so we really need to make the distinction. Here's the big distinction that I make. I like to think of DNA as a recipe. So say you have a recipe book, the DNA are the recipes in it. The RNA is the chef, is the cook. The cook is the one who looks into, so the messenger RNA is the cook. They're the ones who look at the recipes, which is the DNA, and then make the meal, make the dish, whatever you're cooking. And then the what they make, the proteins, are the meal. So say you're cooking lasagna, then the recipe for lasagna is the DNA. The cook, the one who's making the lasagna, is the mRNA, and the lasagna is the protein. All right. So as the same analogy applies, we know that. So one question that's arisen is, well, can the mRNA insert itself into the DNA? Could the vaccine somehow change the recipe, change the DNA? And no, this doesn't happen. It's the same as thinking about a chef somehow putting their hand on the recipe book and the recipe book being rewritten. The chef is a person. It's not the same thing. And so it doesn't work that way. The recipe book is a totally different thing. We're not changing the recipe by doing this. All we're doing is adding a new chef that's coming in. So whereas before each cell would have had its own cooks doing stuff, now we're just having a separate cook come in with and cook up some stuff in the cell. And what it's cooking up is this very, very, very small piece of protein, that's the spike protein, not the whole huge, enormous virus of the SARS-CoV-2 virus, but just a tiny, tiny, tiny little clip of the tip of the spike protein. And that's all it's cooking. The RNA degrades within it. So it's as if the cook goes away within a short period of time, and then all you're left with is the spike protein that's circulating around the bottom. That's just a tip of it. It's not even the whole thing, just a tiny, tiny little tip to create the antibodies to it. So it's really pretty safe in terms of RNA drugs that have been investigated. So the first RNA drug was actually was approved and released in 1998. So different types of RNA drugs have been on the market for years and years now. A second type of RNA drug was developed and released developed years before this, but approved and released in 2004. And then 2018 was a different type of RNA drug was produced. The siRNAs drugs. Basically, these are the four different ways that RNA is being used. The antisense RNA basically just binds to mRNA and just degrades it. The siRNA, the small interfering RNA, sort of just binds to it and breaks the RNA, and so sort of disrupts it that way. The key one here is the messenger RNA that we're looking at. And basically, like I said, it's as if a cook is coming in and just making a new, small, tiny, tiny little protein. It has nothing to do with the recipe book, so we really don't have to worry about that. The bottom line here, I'll just do one little other thing. So you see, these are all the drugs that have been released since 1998 that are RNA drugs. I know it's a little bit hard to see. You can look it up on Google, but typically they've been for some genetic conditions: familial hypercholesterolemia, muscular atrophy, muscular dystrophy, so just some hereditary stuff, age-related macular degeneration. And so you can see there's a lot of drugs that have been on the market that many people have been using for years and years and years. We understand the general safety profile. These drugs are generally safe. The vaccine trials have demonstrated that they're safe. So this is not something we need to worry about. That's the end of that question. Yes, so definitely take the vaccines as soon as we are able to.
Great, thank you. So, but if some communities are more resistant to get a vaccine than others, will there be more outbreaks there within those communities?
That is a really good question. So we mentioned previously that there's vaccine hesitancy that looks at a state level. We do see that different states are varying in how many people will get vaccinated. Let me dig into this a little bit more, just because this could be problematic. States that don't get enough people vaccinated, so there's two types of problems. States that don't get enough people vaccinated, the first is if the high risk people don't get vaccinated enough, and then if they get infected, they're still going to be at high risk of hospitalization and dying. And so that's bad. And then the second thing is this herd immunity question, which is still an open question. But presuming that the vaccine reduces how contagious people are, even if they are infected, then this question of vaccine herd immunity that could be at risk if we don't get a sufficient number of people vaccinated in some of these states. And you can see there's some states that are at risk of this here. So let me click on some really interesting polls that have been done that have been tracking this very question. So because of poor leadership, and this is just objective, poor public health leadership coming from the federal government, what we see is wide variation in Democrats versus Republicans. And first of all, how severe a health risk they think SARS-CoV-2 is, but then that also relates into how likely they are to get vaccinated. So right now, a little over half of Democrats think that SARS-CoV-2 is a severe health risk in their community, while only 30% of Republicans do, which is abysmal. It's that we're in an epidemic, and only 30% of Republicans think this is a severe disease, where we've had over 400,000 excess deaths associated with this epidemic in 2020. It's astonishing. This is going to be something we look back in history, and future generations are just going to be astonished. But when it comes to the vaccine, this is where it gets really interesting. All right, so according to this survey, approximately 2/3 of Democrats say that they want to get the vaccine when it becomes available, whereas under 50% of Republicans say that they will. And so this could be problematic, because if under half of Republicans say that they will, then counties that are more heavily Republican are really at risk. And right now, no one's been talking about mandating vaccine use, but I don't know how that's going to roll out. We do know that companies are allowed to demand that their employees get vaccinated as a condition of employment. And so we do, but there's politics behind that. Companies don't want to seem bad, so they need to sort of manage how that rolls out. And so I don't know what this is going to look like. But I know that these numbers are not sufficient to be sufficient. They're nowhere near sufficient to what we need. There's some very interesting polls here. This was done by the Kaiser Foundation. But let me go into some of the key findings here, because this is interesting. First of all, people have been more motivated to get vaccinated as the months have gone by. So when they asked the question in September, if people will definitely or probably get it, there were less people than there are in December when they re-asked the same question. Clearly, there's a shift. A lot more people are getting enthusiastic about seeing it. And as more people get the vaccine, I fully believe that we're going to see an even greater shift, because when they see their doctors getting the vaccine, and if they're hesitant and they see their neighbors getting the vaccine, then I think a lot more people are going to be willing to do it. These numbers were a little different, but the key interesting thing that I saw here is that there is a lot of variation based on race. And so African Americans, because of true racist history that we've had in this country, based on Tuskegee and other historical things, there's a reluctance and fear among a lot in the African American community to take new medicines, because if they feel like they're being targeted, or to take vaccines. So that's something we're gonna have to work on. But even in those communities, the vaccine hesitancy is going away. The light blue is going away across the board, across all the different ethnicities. Interesting, among Republicans and Democrats. So among Democrats, it's increased. So this most recent study in December, is now based, so that this I think is a little bit more accurate than the previous poll I was looking at, is saying that approximately 86% of Democrats will definitely or probably get it. And whereas only, so slightly above half of Republicans are saying that they will probably or definitely get it. And so at a national level, this relates to 71%, but you see that there's this wide variation. When we look at, I like this one because it really breaks it down by lots of different segments. So you see that the ones, so this is whether they will definitely not get it. So 42% of Republicans are still saying that they will definitely not get the vaccine. They don't care, no new information. They don't care what anyone says. 42% are saying that they will definitely not get the vaccine. Third, among people in general, age 30 to 49, 36% of people age 30 to 49 are saying that they will definitely not get it. People who live in the countryside and rural areas are less likely to get it. Black adults are less likely. Now, as you go through, you can start seeing that there's people that become more and more likely. So essential workers, healthcare workers, 29% say that they will not get it. Even among healthcare workers, it's very interesting. When we were looking at from a public health community at smoking, tobacco smoking, there was a time back in the 1950s where a lot of physicians and nurses and healthcare practitioners smoked tobacco. It was very common. Excuse me. And so went down the wrong pipe.
I'll jump in for a second. And I'll give everybody a preview into an upcoming question about marijuana. Glenn is going to be talking about marijuana, about can marijuana prevent or cure COVID-19? So while you take a few gasps of nice clean air.
Thanks, Rebecca.
Join us.
I'm back. But so the key thing I want to say is that so even among healthcare providers, there's wide variation. And so there are some people who are in the healthcare community who are not physicians. They might have only had 1 year of training. Maybe they're a tech, the healthcare tech that works in the hospital that is on the priority list because they're exposed to patients, but they're reluctant. And so hopefully we're going to see those people be among the first to be more motivated to get it. Also, men are less likely to get it. But interestingly now, as you go it's more and more, so that the average for the population is around 27% right now. And again, I say that it's going to change over time where more people are going to be willing to get it. But it's an interesting trend. And so we can see that people who live in cities, people who live in a household with a household member who has a serious health condition, particularly people over the age of 65, and surprisingly, but maybe not surprisingly, just based on the leadership and the messaging that people have been getting, Democrats are extremely likely to get vaccinated. They're the least unlikely to get it, to say that they will not get it. So this is something we need to work on, because we know that, for instance, in rural communities, that is a geographic description. And so people who live in rural areas are more likely to then be hesitant. So we're at real risk in many parts of the country. So if you combine these, Republicans who live in rural residents or who live in rural areas might be at even higher risk. So this is something we definitely need to work on. Let's go on to then a few more questions. I just wanted to, there's one or two more things. Nothing else too more interesting though. Let's go on to that's it. Oh, one more thing that was interesting here. So this is the question of whether it's a personal choice to get vaccinated or whether it should be everyone's responsibility as Americans to get vaccinated. And this is something interesting too that the next leadership, the next administration is going to have to work on. Approximately 70% of Democrats believe that it is every citizen's responsibility for the sake of being an American to get vaccinated. And only 27% believe it should be a personal choice, whereas it's just the opposite among Republicans. 71% believe it should be a personal choice, and only 26% believe that as Americans, we should do this for America. But so this is something the next leaders are going to have to work on. All right, Rebecca, back to you. Next question.
All right. Goodness gracious. Legislating morality. Wow, this is getting deep. Okay, Sandy, I'm going to ask you to unmute, please. Sandy has a follow-up question about the administration of the vaccines. Thank you, Sandy.
Okay,
Please take it away.
First of all, Glenn and Becky, thank you so much. This is wonderful, and Happy New Year. Hopefully this will be a better and easier year. I don't know what we're going to do, Glenn, when this is all over. We'll miss Sunday nights. But in any event, this is a rhetorical point that kids have to be vaccinated to get into kindergarten by law in most public schools, as far as I know. So I'm not sure why there can't be some equal law that makes adults need that to get into job places or airports, whatever. But that's another point. Howard, what I'd like to know is, I live in Florida and it's now 65 and older are eligible to make an appointment and go. But how would we know if a batch of this vaccine is outdated or if it was a little warm, because a lot of them are administered in lines of cars outdoors. So can we ask the batch number? How can we check the efficacy of the shot you are getting?
I don't think there's any way to know. I think that it's that we need to trust the people who are administering it, that they are going to be doing it sufficiently well. I mean, but this is the same for any medicine that's administered. For any drug, there's always going to be an expiration date. And so we rely on the pharmacists and the people who are administering a drug like this to be aware of it. So yeah, go ahead.
Except that if you're told by your governor, who is in charge, that you need to get rid of all of it, no matter what, that's also rhetorical. Who knows what will be? But
Well, wait, before you go on. So the governor is not administering it, though. All he gets to do is decide the population that can get it. So the physicians that are actually doing, or nurses that are actually doing the administering, they're the ones, and they're competent. These are the nurses and physicians, so we can trust them.
Okay, and what would happen if you did get one that was slightly overdue or slightly warmed? It wouldn't harm you, it just might not be as strong.
That's right. That if there's no reason to think that it would do anything different with safety. The only thing is that the efficacy might go down a little bit, because what's expiring is the RNA it doesn't keep its structure the same over time, and so if it starts to disintegrate, then there's just not enough in there to really give you the antibody response, or so it's not effective as a vaccine.
Thank you.
But
Yeah, thank you.
Rebecca, there's one other thing that I wanted to add to this about the vaccine rollout. So at the rate that we're currently going, let's say 2,000 per week, or 2 million per week, it's going to take 264 weeks to get herd immunity. And it's going to take even longer, over 300 weeks, to get 100% of the people vaccinated. So this is way too slow. There were a lot of news articles over the last week or so really criticizing the vaccine rollout. But one thing I want to point out is that this thing, this. So you can see that it's a rate. We're not administering the same number of vaccines per week. We're ramping up. And so just because there were 1.5 to 2 million vaccines administered last week doesn't mean that there's going to be that much in the following week. And in fact, I looked at this a little bit more closely over here, and on average, it looks like over the last week, we've been increasing the vaccination rate by 25,000 more per day than the day before. And that's approximately 175,000 per week. And so, well, no, it's more than that actually when you add it up. So my point here is that we're going to be so 25 times 7 adds up to 175, but the issue is that it compounds, and so it's 25 plus the 50 plus whatever. And so I didn't do the compounding in here, so let's not look at this. But instead, what I want to point is that the slope of the line is the key thing we need to be looking at. And the slope of the line is increasing dramatically. So just because we were 2 million last week, I think very, very quickly, we're going to be hitting 3 million, then 4 million, then 5 million. The question that we have is, okay, well, say we want to get the population vaccinated within a year. What does the average need to be? So if we want to have everyone vaccinated within a year, then that's, let's say, 52 weeks. Then we're going to have to get to over 10 million vaccinations per week. And this includes understanding that this is a 2-dose. The mRNA vaccine is a 2-dose vaccine. Some of the other vaccines that have not yet been approved, but maybe shortly, are only a 1 vaccine dose. But this is something that's going to be critical. And this is for within a year. If we're trying to do it within, say, by the summer, whoops, let me go this way. So let's say 25 weeks or less, 20 weeks to 25 weeks, then we're talking about 24 million vaccine administrations per week on average. And what that means is if we're only doing 2 million last week and maybe 2.5 million, 3 million in the coming weeks, then we're going to have to do even more than that in order for the average to hit that amount. So we're not anywhere near where we need to be, even with this ramp up. So the new federal administration coming in is really going to have to do some better work. One other thing that I was going to talk about here was that the federal government really dropped the ball on this. So the federal government has among the best logistics competency. I spent several years working for the Military Health Service, working for Veterans Health Administration. They used to say that someone who had the graduate degree in logistics and had the advanced training and the experience in logistics was worth their weight in gold. And I used to meet a lot of people who are worth their weight in gold who had this. And so, and a Gantt chart is an example of a tool that they might use where basically, even though the logistics are complicated, a philosophy professor once told me that being complicated is not the same thing as being difficult. When something's complicated, you can just break it up into smaller and smaller parts. And then eventually each of the smallest parts are really simple. And someone who does logistics can take something that's really complicated process and just break it up into the smallest and smallest parts. And that's different than something that's difficult, which can't be broken down into smaller parts. But so what we're talking about here is not difficult. It's just complicated. And so people who know logistics and the best, most competent people in logistics that I've seen are affiliated with the federal government in terms of across all work processes that I've seen in different companies and different at the state level doing work. And it's when you think about military, for instance, needing to get logistics exactly right, that you can't win a war unless you have the logistics top notch in terms of getting the food and bullets and medicine and everything where it needs to be at the same time. So we have the competency. Here, there's tons of dependencies. You know that if a drug doesn't get to a certain place by a certain time, then you will not be able to administer it on this day at this place, and this person down here will not get it. And so what they do is all the different steps, you have all these dependencies that connect everything together. They know who needs to do what, they know how long things take, and they can track it over time and know for every day, are we on schedule? At the end of the week, are we on schedule? What can we do to ramp up where we need to be? And a good person doing logistics does all of this. The problem is that the federal government, they had 9 months to work on this. They told us they were doing Operation Warp Speed, but all that meant was they were going to get the vaccine, deliver it to the states, and just drop it at the states. And the problem is the states don't have the resources or the people who have enough people who do the logistics to be able to successfully execute this. And so it's going to continue to fail unless we have a partnership with the federal government. And this is what we've seen so far with just the first dose needing to be administered. The question is now adherence. So we know that a second dose has to be administered. How are we going to ensure that everyone that's gotten their first dose comes back to their second dose? This is a really important logistics problem, and you need the best in the country, the people working on logistics, working on this. And currently, that's simply not the case. And it's something that we can fix. Logistics is something that we can fix with the new administration, with enough money, funding, and the right people, we can fix this. But it's going to take some time to fix this mess that we've that the rollout that's really been a mess so far. All right, Rebecca.
Okay, that's really interesting, Glenn. And
Time for one. You want to do that one last question?
I think we have time for one more question. And as I mentioned, this last question is about marijuana. Can marijuana cure or prevent COVID-19?
All right, so let's talk about this one. So the short answer, unfortunately, for people who use marijuana is that it does not. And so there have been some articles, and this is why people have been asking me this question. There have been some articles that suggest that where there's some researchers, I think they were in Canada, who have sort of developed some new strains of marijuana. And so this is not something that's publicly available in terms of the strains that are available at different health clinics or in states in which it's legal. But it's these researchers developed this new strain, and what the new strain does is it decreases the level of ACE2 gene expression. So they have a hypothesis that if the ACE2 genes go away or are reduced, that it will reduce the amount of SARS-CoV-2 infection. So first of all, this is just a hypothesis. They haven't even done any clinical trials on this. And so we don't even know. All they have is some very early evidence that means it could be suggestive. But right now it's a theory. Who knows in the future? It's not going to be done anytime soon for this epidemic. But the other thing is that we need to worry about if some strains of marijuana decrease the amount of ACE2 gene expression. So the ACE, again, this is the ACE2 receptor is what the SARS-CoV-2 virus binds to. The worry is if some strains of marijuana decrease ACE2 receptors, then the worry is that there are some strains of marijuana that could potentially increase the ACE2 receptors in the body. And so we just don't know enough about this. Right now, I wouldn't say that we know enough to say that marijuana makes things worse for SARS-CoV-2 in terms of people more likely to get severe or better. Right now, there's no evidence that of clinical trials that have been looking at this. And so right now, no, marijuana cannot be used to prevent or treat COVID-19.
Okay, well, thank you for clearing that up. All right, so that brings us to the end of our session tonight. Thank you to everybody who has submitted questions during the week, and thank you also to those who submitted questions during our conversation tonight. If you have questions during the week, please send them to me or to Glenn. We appreciate it, and of course, continue to be safe, wear your masks, wash your hands, and we look forward to seeing you all same time, same place next week.
Thanks,
Thank you,
Rebecca.
everybody.
Thanks,
Thank you,
everyone.
friend.
Have a great week. Bye-bye.
Have a good week.